afternoon. Can everyone hear me okay? I don't know if you all feel the same way that I feel, but I would have loved to have met many of you 8 or 9 years ago when I started the work I was doing. It's been really great to hear about some of your experiences. My name is Paul Biondich. This clicker isn't working.
They gave you the wrong one. Get the Mac one.
Get the Mac one. Okay, 1 second, sorry. Is there another clicker? A Mac clicker? Let's try that one. There we go. So anyways, I'm Paul Biondich. Just really briefly about myself, I'm a practicing pediatrician and I'm a geek. And I kind of straddle the fence doing medical informatics work at Indiana University. And it might not surprise you then when I say that I believe that information is care. From my perspective, healthcare is a very information-centric business, and to be good at healthcare, you have to be good at managing information. And I'm very fortunate to work in an environment that's been thinking about information technology as it applies to healthcare very early on, in fact, in the early 60s. And as someone who works with these systems and has helped design them, once you have them, it's kind of hard to do without them. They're a very fundamental part of how we care, at least in the environment that I work in. And so when some of my colleagues started this academic partnership with a university in Kenya called Moi University, and they were able to experience some of the things that the Kenyans were experiencing, they realized some of the challenges around health delivery and then, more importantly, the information management, and realized that something else needed to be done. Imagine being an HIV patient and seeing a different clinician each time. And that clinician simply has enough time to see you in the milieu of like 70 to 80 other patients they're seeing that day. And they have really no tools to help them manage the information for a given patient. One of those patients that I ultimately had the chance to meet was a man named Musa. And the day this picture was taken, Musa was taken, was carried actually for an hour by his brother to a matatu in Kenya. And he then took a matatu for 2.5 hours to the hospital. When they took this picture, he had no pulse and couldn't speak. This is also Musa, after being correctly diagnosed with HIV and having 4 months of treatment. Has anyone ever heard of the Lazarus effect before? Yeah, so you hear about the Lazarus effect in medical school, but then when you actually see it face to face, it is a very eye-opening experience. And you know, people like Musa really helped the global health community understand that the problems around infectious diseases like HIV are not really treatment challenges, they're more systems challenges. I almost didn't get a chance to meet Musa. My mentor in 2004 asked me to come into his office and said, I need you to go to Kenya for a week to be a consultant. And because I was so caught up in my own emerging career and because I'd never traveled internationally, I actually initially said no. And ultimately, he cajoled me into going. And it was probably one of the best things that ever happened to me because I had one of those moments of clarity when I finally went to Kenya and realized that global health was something I really wanted to do, and I've been kind of looking at it ever since. And while I was there, I had a chance to meet a bunch of really bright Kenyans who at the time were responsible for the information management of the environment in Eldoret. And they had all the capacity to be able to do something that was going to meet the needs long term, but they just simply needed a nudge to take it to the next level. And so because of all of that time that we spent, it was about a week and a half, we decided to, you know, on the spirit of excitement, conceive what was then called the AMPATH medical record system. And I remember coming back and talking to my mentor, a guy named Clem McDonald. I was really excited to tell him about the great work we were going to do in Kenya, and he proceeded to tell us that we were both naive and idiots. That the work of building medical record systems is the work of dozens, if not hundreds of people. And you know, we really needed to think differently about how we were doing the work. And I remember being really upset by what he had to say, but ultimately realized in retrospect that it was exactly the right advice because we were going about it thinking about us building it alongside the Kenyans, and we maybe took a step back to see maybe other ways we could think about doing information management. And so we went and looked out in the field, and what you saw were a lot of examples like AMPATH. At the time, very simple systems or no systems at all, and really no way to take advantage of other people's work. Until we ran into a guy named Hamish Fraser. He's the guy in the bottom left of the picture. Hamish leads a group called Partners in Health. He turned out that he was leading an initiative that was almost in exactly the same position that AMPATH was. And we decided that maybe we could work together and maybe we could build something that would meet each other's needs, but also support each other. We would share the resources. We also met, to me, a very important person in my career, a guy named Daniel Kaiwa, who's a Ugandan that was responsible for building information technology, an information system for Uganda, or Ugandan clinic. And he is a coding wonderkind. He could code circles around most developers in the US. And the reason why it was important for us to meet him is that we realized that perhaps the development of these systems could also be done locally as well. And he actually inspired us and realized that maybe it was possible to do this locally. And so that really got us to think about this idea of building with others and building perhaps a group of people that could work collectively on solving this problem. And that's what gave birth to OpenMRS. This was the first logo for OpenMRS. It's pretty snazzy, huh? It's my colleague, Burke Mamlin, made it on his laptop. We started building OpenMRS by thinking about what the information model was for how health is delivered in clinical settings. And then we started building technology on top of that to read and write the database, and ultimately also built a customizable user interface that could be used and customized depending upon the clinical environments that we were working in. Around the same time, a guy named Chris Seabrecht's, one of those people that some of you probably in the audience know, he's kind of like an angel on earth. He came to us and said, you're going to have people that want to use this, and so let me build an implementers community to support people getting support from each other. This is the picture of the first implementers meeting that we had in 2005. And over time, those meetings grew and grew. They got larger. And then philanthropy started getting involved, like the Gates Foundation, CDC, and you can see all of them listed. And we started to realize maybe there's something really going on here that's beyond the needs of our own individual environments. And so we took a step back and we said, we probably need to think carefully about our mission and vision and values. And there's 2 points about this that I'd want to make particular notice of. One is that our focus was on improving healthcare delivery in resource-constrained environments, and not by doing this all for ourselves, but by coordinating a global community. That's fundamental to what our community was all about. And because we were getting to the point of getting more sophisticated, I went and spent $500 and got another logo. This is the logo circa 2008. The next thing we realized, this stuff started getting implemented everywhere. And it was really a surprise to a lot of us just how quickly it spread. And a lot of people started asking us, what was it about OpenMRS and what you all did that allowed it to grow in the way it did? And at the time, I felt it was like luck, good timing, good fortune, clean living. But in retrospect, I think part of the reason why we were successful was because we identified up front a shared mission and a collection of shared values. And I want to talk about some of those really briefly. One, that it's very important to me, and I think very important to members of the community, is patients are first and others follow. Basically, Joe Mamlin said, care will lead the way. And you can be a lot of things to a lot of people, but by having a very circumscribed mission and staying within that swim lane, we felt like we were able to keep distractions away and stay focused on being good at one thing. Freely available. So, it's one thing to give away free food. It's another to give away the recipes and to give away the ingredients. And you might have heard about that in technology. It's called open source. And so we very much believe in giving all of those components away. But it's not simply enough to give them away. You have to also explain to people why they fit together in the way that they are designed and what the purpose of each of them is. So being actively transparent is different than just giving it away. It's very, very difficult when you're thinking about building medical record systems to stay focused on the actual needs. You want to conceive, because you think it's going to be a big system, you think you need to design it up front. And I think by avoiding imagined needs, we've been able to stay very focused and develop just as the needs necessitate. Most of these open communities, if you go and research them, you realize that they have a common open foundation that's based upon standards, and we've really benefited from that in the work that we've done. This is one of the things I'm very passionate about, because it's much easier to rebuild something from scratch than it is to take advantage of things that other people have done. And so we've made a very deliberate effort to say to people in our community, don't build it unless you absolutely have to. We believe that the community is really the foundation of what allows us to be successful, and people like me are probably the least important members of the community. It's really the foundation of the people who are using it and who are implementing it that really the community needs to be built upon, and ultimately I hope that my leadership role in this community will be made obsolete by a number of other people that will step in and push me out of the way. And instead of doing the work of the community on our own, instead of me writing the code and doing the data model work like I did way back when, we think it's really important to bring in people that have less experience to doing these things, in particular people that are in the environments that we're serving. We want to help build up their capacity and make them active participants. People like Garima, who's from India, she was doing an internship, a Google-sponsored internship, and she started by writing some code. After doing code, she started doing developer documentation, and now she is part of the welcoming community that welcomes 5 to 10 new volunteers a week to OpenMRS. We also started seeing these people online with these interesting pseudonyms, and they just start showing up and start writing code for us. They start taking off some of the tickets that we do, and then you start to realize that these are people that want to either learn something from writing software, they want to inherently be philanthropic with their time. I've never met any of these guys. I don't think that many people in the community have met them. They are these people that just come and volunteer, and they're increasingly a part of our community. I'd like to make a particular mention of Saranga, someone that's very near and dear to my heart, who was also an intern in the Google-sponsored Summer of Code. He ultimately decided he liked what he was doing so much that he ended up working for a not-for-profit doing health informatics and is now doing a PhD in health informatics. And so he's actually turning into a professional just because of the opportunities that the community provided him. And that's exactly what we're trying to go for. And probably I'd say the most important value that we all have is following thought with action. So for whatever reason, our community attracts doers and dreamers at the same time. And we think that that's a really, really important foundation to what allows our community to grow. And I'd like to just maybe share with you a couple of those people with me. So that guy to the right of me, Alvin Marcello, the better looking guy, he started a national implementation of OpenMRS in sponsorship with the Ministry of Health, and he did that actually by creating a whole academic curriculum within the university system that was training nurses and professionals how to implement these record systems. It was just an amazing work, just a force of nature that Alvin was able to see this through, and he's done some really amazing work in Philippines. Rutger Kuba, some of you might know, was the health coordinator for the Ministry of Health of Rwanda. It was really important for him and his national implementation of OpenMRS to build a local ecosystem of both ministry personnel and also commercial personnel that are doing an implementation of OpenMRS that's scaled up into, I think, 400 clinics as I last understood. Some of you might know Gabu Mendy. He came to me a few years ago to implementers meeting and tapped me on the shoulder and said, I want to implement OpenMRS in our series of clinics in Nigeria. I didn't realize at the time that the clinics he were talking about were around 400 of these clinics, all that were supporting HIV. And without any help from any of the founders, really ramped up, and I think they're now in over 120 clinics. Just amazing work. Judy Wawira, I don't know, are you here in the audience, Judy? Oh, there you are, Judy. So Judy, I met back before she had gone into her residency. She actually, on her own, has any of you been to the Kibera slum in Kenya or know about the Kibera slum? It's probably one of the very toughest environments that you can imagine. And there are a series of clinics in Kibera slum. And Judy solved the problems around information management in one of those clinics called Shining Hope. And she just on her own took OpenMRS and implemented a record system for that clinic. Just amazing. And she's now doing health informatics work as part of her career passion. Tobin Greenswag is a guy who came to one of our implementers meetings, and we have this unconference style. And his first presentation was why I'm not going to implement OpenMRS. So he was a real skeptic at first, but ultimately stayed with it and has implemented OpenMRS in a refugee clinic in Tel Aviv. Really, really amazing work. Not only are there these individuals who have done these really amazing activities, but there are also increasingly businesses. Joaquin Blaya, leads an organization called eHealth Systems Chile. And he's built an implementation of OpenMRS that supports community healthcare workers, and he's in the midst of a national rollout. And has built quite an interesting financial model around the long-term sustainability of systems on top of our platform. Another guy who some of you might be aware of is a guy named Roy Singham, who's the founder of an organization called ThoughtWorks. They're a $500 million a year software consultancy firm, and they've decided to participate in OpenMRS as both a philanthropic good and a learning activity for their software developers. And so they're putting the equivalent of literally over $1 million a year into the community through their work in OpenMRS. And so, that's what our community is today. Our community is really an ecosystem of a whole bunch of people way smarter than me, way more talented than me, that are emerging this community of practice. We've heard a little bit in the lectures about community of practice before. And you can see that we actually have what I think is a reasonable logo now. That was actually was a gift from the group that made the Nantucket Nectars logo. And you can see that our community, especially in the past 3 years, has really started to take off. We have, as I said before, 5 to 10 new volunteer requests a week that we manage. And really the trick becomes taking all of those contributions and taking the work and breaking it into small chunks that can be perhaps broken down and perhaps brought back into a cohesive whole that have a lot of value to people in the broader community. And so that's my talk. Thank you very much for your time.